on behalf of the Society of Critical Care Medicine's ARDS Innovation, Knowledge, Education Group. Thank you for joining us. I'm Javier Amador Castañeda, and I am a respiratory care practitioner at Columbia University Irving Medical Center in New York City and co-chair of the ARDS Innovation KEG. For transparency, I also serve as the North American representative on the Council of the European Society of Intensive Care Medicine, and I have no additional conflicts of interest to disclose. Before we begin, a sincere thank you to those who attempted to join us on July 31st. We experienced technical difficulties and made the decision to reschedule so we could deliver the quality you expect. To ensure a seamless experience today, the lecture you're about to see has been pre-recorded. Professor Marcelo Amato will then join us live for a 15-minute Q&A at the end of the session. This is a truly global event. We're meeting here on Zoom and streaming simultaneously on LinkedIn Live and YouTube Live, bringing together clinicians, researchers, and trainees across time zones. We appreciate your flexibility and your commitment to advancing lung protective care. I want to recognize Christy Rose, Vice President of Sales and Marketing at Temple Medical, for her partnership and support in making today's webinar possible. Christy, thank you for all your help. And now let's move on to some housekeeping rules. We will start the recorded program promptly at 2 p.m. Please enter your content questions in the Q&A panel at any time. We will curate them for the live 15-minute Q&A with Dr. Amato after the talk. Use the chat only for technical issues so our team can assist quickly. In the resources section at the bottom of your screen, you'll find open access articles relevant to today's topic, registration for our August 27th webinar, titled ECMO and ARDS From Rescue to Refinement, a session you won't want to miss, and a link to learn more about SCCM membership. We're also joined by my co-chair and today's moderator, Dr. Bushra Mina. Dr. Mina is the Chairman of Medicine and Chief of Pulmonary and Critical Care at Northern Westchester Hospital in New York. Now it's my privilege to introduce our speaker. Professor Marcelo Amato is a world-renowned expert on protective ventilation strategies and a pioneer of electrical impedance tomography as a technology solutions for a new approach to ventilation monitoring. Dr. Amato is currently the supervisor of the respiratory ICU of the Hospital das Clínicas and a practicing pulmonologist and critical care physician. He holds a faculty position as professor at the #1 global university in Brazil, La Faculdade de Medicina da Universidade de São Paulo. In the last 10 years, Dr. Amato has presented his research at more than 350 international scientific events as a guest lecturer. His most important publications include 2 original works, in 1998 and 2015 as the first author in the New England Journal of Medicine and a cover article in the American Journal of Respiratory and Critical Care Medicine. His scientific work has already deserved 12 editorials and more than 4,000 citations in international scientific journals. Technologies developed and adopted in medical practice include volume-assured pressure support ventilation, a ventilator modality available today on more than 100,000 artificial ventilators around the world, and also electrical impedance tomography, with scientific papers that deserve the Siemens Science Technology Award of 2006, and with a partner company and developer who won the Innova Saudi 2015 award from ABIMO. Electrical impedance tomography is licensed for clinical use in Brazil, Chile, Peru, Saudi Arabia, and European ICUs. The technology continues to evolve with partnerships between USP, large international and national research centers, including the universities of Colorado, Harvard, Uppsala, and NASA's Kennedy Space Center. So now, please join me in giving a warm welcome to Professor Marcelo Amato.
Amato. I'm from the University of São Paulo, and I'm very pleased to be here as an invited guest for the Society of Critical Care. And I'm especially thank you to Javier for organizing this session. We are going to talk about protective ventilation and the use of electrical impedance tomography for this purpose. This is an area that I have been investigating for the last 20 years. So protective ventilation started in the 1990. It was the first time that we coined the term when we published the first paper showing very good physiological results in 28 patients with ARDS. Later on, 3 years later in 98, we could show a very good results in terms of mortality in 53 patients. For this purpose, we used reduced tidal volumes, permissive hypercapnia, higher PEEP levels, gentle recruiting maneuvers, and reduced driving pressures. Driving pressures at that time had a maximum value of 20. This was a history of success. We are very pleased with the results, but the next years were very confused. And the reason is because we had 3 new trials on protective ventilation, where the investigators were trying to reduce the tidal volumes, and the results were showing opposite trends. So this was very confusing. It was hard years to cope, because some people started to use high tidal volumes back in my hospital. But then finally, we had the ARMA trial, that finally established this important role of protective ventilation. It was really a history of success. A lot of enthusiasm in the scientific community, because for the first time we had a strategy that was clearly reducing mortality in ARDS. There was some priority given too much in terms of tidal volume. I was a little bit skeptical about this, because we believed that the whole strategy was important. But anyway, the big emphasis after the publication of the ARDS-NET trial was the use of small tidal volumes around 6 mL per kilogram. But what about the PEEP and the important role of the recruitment of the lung? So this was the target for the next years, and we had lots of new studies, and they were all trying to address this important question. So we had the alveoli trial in 2004, and we had then the French, the Canadian, and another American trial. And all the results had a small trend, but they were not conclusive. And finally, some years later, we had the ART trial that had a very opposite results. In fact, the ART trial was showing increased mortality. So even after having a total number of 5,000 patients included in clinical trials, we didn't have an answer about the use of PEEP. And finally, we had the COVID times that were very confused, and everyone was scared about using higher PEEP. And then the PEEP question was kept open. Fortunately, along these years, we had the establishment of some strategies like the prone positioning, the use of lower driving pressures, and also some awareness about the problem of patient self-inflicted lung injury. I consider that all of this was very positive. I believe also that all these strategies, they were helped by the use of EIT in some preliminary experiments. Why the confusion about PEEP? Why it was, let's say, relatively easy to conclude that high tidal volumes were bad, but why the PEEP quest was so difficult and we could not find a solution to show the protective effects of PEEP? I believe that because PEEP is a much more complex problem. It works beautifully in animals, but it's hard to reproduce some conditions in clinical trials. Just to give you some idea of the impressive results in animals, this is a not so old study that we did in 2015, in which we showed that by using a higher PEEP, we could reduce this inflammation showed in PET. So if you compare these two animals, these two animals here, they use the same tidal volume in this group, in which the PEEP was titrated by electrical impedance tomography, and this group that used the ARDS-net low FiO2 PEEP table. And we can see that there was a remarkable difference in terms of inflammation, cytokines. And so the results were quite impressive. And it's really frustrating that we cannot reproduce these results in clinical trials. So, which is the reason for this? I think we have to consider that the complexity of PEEP arises because PEEP depends on the gravity, and thus it has a very strong influence with body mass index, with individual anthropometry, anatomy, and also with bed position. Not to say a little thing about expiratory muscles, but let's keep only this part of the story and the gravity effects of PEEP. It's complex enough to tell us that we need better measurement at the bedside. These are the recent trials on PEEP after the year 2000. As you can see, all of them, they had non-significant results. They were showing some trends towards an improved survival. For instance, when Brielle did this meta-analysis, he could show that there was some impact of PEEP in reducing mortality in patients with PF ratio below 200. However, when we had the publication of the ARTE trial, it was the first time that a high PEEP strategy with recruitment maneuvers were increasing mortality. So this is mortality increased after the use of recruiting maneuvers plus high PEEP. So this was very frustrating, and also telling us that the method, or depending on the way that we are choosing PEEP, the situation could even increase mortality. So 6 trials and no conclusion about. Recently, in a review proposed by Menga and Laurent Brochard, they were discussing some strategies to titrate PEEP, and they were calling attention to the recruitment to inflation ratio, which is a very practical and simple way to analyze the recruitability of patients. And also they were talking about electrical impedance tomography. And this is exactly what we will be discussing here, because they were precisely calling attention to the unique aspects of EIT to address these PEEP quest. What is electrical impedance tomography? It's a functional image that you can get at the bedside and give you very valuable information. This is a CT of a patient with pneumonia, and we can clearly see that the EIT can tell us where the tidal volume is going to inside the lung. And then we can precisely target the, let's say, the residence, the location of the tidal volume going to the baby lung of patients with ARDS. And then another advantage of EIT, and especially in this context, is that the EIT is very important and very easy to tell us about the effects of gravity. Consider this a small animal, a rabbit, the size of a neonate. This is the lung of this animal when from the perspective of the belly of this animal. And this is the right lung diaphragmatic surface, the left lung diaphragmatic surface. And this is an image taken at 10 of PEEP. And now we reduce the PEEP to 0. And we see here, like a knife, the effects of gravity and the effects of superimposed pressures, which means that because of the weight of the structure of the lung, and because the lung is supported by the contact with the thorax, transpulmonary pressures at these regions of the lung, they were below +2 centimeters of water. And this is not enough to keep the lung open. And you cannot have tidal ventilation if you have low transpulmonary pressures like this. And the reason why we have this level is because we have a gradient of pleural pressures, and we need negative pressures to have a positive transpulmonary pressure, which means that your alveolar pressure has to exceed the pleural pressure to have a decent alveolar ventilation. And this is something that has been shown now repeatedly in physiological studies. So the lung, even normal lung, cannot stand negative transpulmonary pressures. This is the main cause of atelectasis in patients. We don't need some surface tension problems, surfactant problems. Just negative transpulmonary pressures can create this terrible scenario at the bedside. And now to the point that nowadays, when we see CT of patients in our ICU with this aspect, we know that we have been ventilating this patient with not sufficient PEEP, and the patient transpulmonary pressures at the dependent part of the lung must be close to 0 or negative. And this is easily perceived by EIT. When you look at a baseline EIT image and you see this lack of dorsal ventilation, and we can see here less than 24% of dorsal ventilation, we know that this patient has massive dorsal atelectasis. This is the image of a patient that is well recruited and using appropriate levels of PEEP. So typically, a well-ventilated patient has slightly more dorsal ventilation than ventral. And why? It's because we have more alveolar sacs in the dorsal lung region. So we should have, in normal conditions, a little bit higher dorsal ventilation than ventral. And this is the typical scenario when your PEEP is insufficient and your transpulmonary pressures are negative. We can see here that you can achieve up to 91% ventral ventilation. So this is very abnormal situation. Looking at the CT machine or using CT images, we can clearly see this scenario. For instance, this peak is now with an open lung condition at a high PEEP, either in supine or prone. But when we reduce the PEEP, not very low, 11 centimeters of water, this was enough to cause negative transpulmonary pressures in dorsal lung regions here or ventral lung regions here, and you have immediate alveolar collapse. How we can use EIT to detect this more precisely? By doing this PEEP titration procedure that is now available in every brand of EIT machine. You start from a high PEEP, you see some areas of overdistension, and then progressively, when you decrease PEEP levels, you started to see areas of lung collapse, typically bilaterally in dorsal lung regions. And this progress with every step of PEEP downwards. Then after having this procedure that takes less than 5 minutes, you have a kind of menu where you can see different PEEP levels, different levels of hyperdistension, and different levels of collapse. And for instance, if you have to choose a certain PEEP level that you feel comfortable, for instance, in this case, 15 or 17 centimeters of water, this is the best choice in terms of collapse and hyperdistension. You could ask yourself now, Is this really the best solution? Let's see which are the evidences we have today. So this procedure, called the Costa approach, typically produces this kind of graph. So you have in red the collapse curve along different PEEP levels. So collapse was 0 until reaching a PEEP of 15, and then we started to have massive collapse. And then we have here the hyperdistension curve, and we can see that at a PEEP of 5, hyperdistension was 0, 0, 0. Then when we achieved the PEEP level of 15, hyperdistension started to increase exponentially. And then you have the crossing point, or it means a PEEP level in which you have equal levels of alveolar collapse and alveolar overdistension. Is this the best solution? We have now evidence to say so. So typically, this is the best solution in terms of lung physiology, and as we are going to see, in terms of hemodynamics also. And interesting enough, in very recent studies, we have shown that this also coincides with a slightly positive transpulmonary pressure, which is very coherent with our understanding nowadays. So we are just giving enough pressure inside the alveolar sacs to have a slightly positive transpulmonary pressure. And then because of this, you have minimum amounts of lung collapse and minimum amount of overdistension. How secure, so how confident we can be that we are really measuring lung collapse in a reliable way? There are now multiple studies showing that EIT and CT, they coincide very well. So if you do a quantitative analysis of lung collapse based on the lung mass, you can have exactly the same results as the estimates of EIT are providing you at the bedside. Let me give you some examples of this titration and let's say, how much this can help us at the bedside. This is something that we call an obesity model. It's acute obesity because this animal was previously normal, and then by putting some weight on top of his abdominal cavity, we can increase abdominal pressure and, as a consequence, pleural pressures. So immediately, this animal is going to have a lower transpulmonary pressure for the same PEEP levels. What happens with the EIT PEEP titration in this condition? First, let's see when the animal had no weight. This was his PEEP level suggested by EIT. Why? Because I had the crossing point between collapse and overdistension, and fortunately this animal needed very low PEEP levels to keep an ideal lung condition where collapse was low, hyperdistension was low, and compliance was close to its maximum. But then we put the weight, and now the situation changed a lot. Look at this. Now I see a dramatic and exponential increase in collapse levels, starting from a PEEP of 14 down to a PEEP of 5. And the hyperdistension was practically 0 below this PEEP level. So this graph is telling us that you can apply a PEEP level of 40 in this animal without risking any hyperdistension. Let's see now the influence of position. This is the titration of a patient in supine position. Fortunately for this patient, he needed just 11 centimeters of water of PEEP. And you can see small levels of lung collapse, small levels of hyperdistension here in blue. And we were reaching almost the maximum compliance of this patient, which was around 40 mLs per centimeter of water. And then this patient was submitted to Trent-Dallenburg. Immediately, we saw a shift in the curve. Now, lung collapse started to happen at much higher PEEP, and coherently, hyperdistension also needed a higher PEEP level to occur. Look at this. Hyperdistension here was practically zero at a PEEP of 15, while when this patient was in normal supine, I had already 20% of hyperdistension, which completely disappeared when this patient was in Trendelenburg. Why? Because now I have all the weight of the abdominal cavity increasing pleural pressures, and thus transpulmonary pressures are lower. And now, for instance, I need a much higher PEEP to cause alveolar overdistension. The same happens when changing from supine to prone. This is the titration of this patient in supine. PEEP level of 14 would achieve minimum levels of collapse and hyperdistension. But when this patient was in prone, we can see that we needed much higher PEEP levels to be close to the crossing point. And again, at this crossing point, minimum levels of collapse, minimum levels of hyperdistension. How can you explain this? Everyone tells us that prone position decreases lung heterogeneity. How come that this is possible? You have to think that many times when you put the patient in prone position, depending on his individual anatomy, you can have, for instance, a big and protuberant belly. And when you put the patient in prone, this is going to squeeze the abdominal content, increase the diaphragmatic shift to the lung, and then you are going to have increased pleural pressures. So despite the fact that in prone, you may have a lower gradient of transpulmonary pressures, the overall offset in pleural pressures can be much higher in prone position, and this particular patient needed much higher pressures to have positive transpulmonary pressures and minimum levels of collapse and hyperdistension. So position is a very important topic for PEEP titration. And if you change position, either supine to prone or supine 30 degrees to supine 10 degrees or Trendelenburg, you have to change everything. And this is one of the reasons why the history of PEEP has been so confused. Another important topic, look at this study performed in severely obese patients. Look at this X-ray immersed in a sea of fattiness. You can see here that we have the PEEP titration. This is the collapsing curve. This is the hyperdistension curve. And look at this. The crossing point in these patients is at 21 centimeters of water. So you need a very high PEEP to start observing minimum levels of hyperdistension. So it's hard to believe that these patients needed so much PEEP to be in a kind of neutral lung condition. But this was confirmed by the transpulmonary pressures measured with an esophageal balloon, confirming that at 21 of PEEP, transpulmonary pressures were very low, just slightly positive and close to the ideal scenario for this patient. This is why if you are using the conventional PEEP approach to this patient, you are going to work with a completely closed lung. This is the patient when using a low PEEP FiO2 table according to the ARDS net. Something also remarkable in those patients is that when we applied those principles and when we started to apply PEEP selected by EIT, we could find a very interesting relationship between the drop in driving pressure and body mass index, which means that the higher the body mass index, the larger our patient, the larger is going to be the benefit of using the titrated PEEP according to EIT. And this is why now it's a very important routine in many hospitals that any patient with slight increments in body mass index, they can only be operated or they can only receive mechanical ventilation if they are monitored with electrical impedance tomography, or at least with an esophageal balloon. So the higher the body mass index, the greater is going to be the benefit of a personalized strategy. This can also be shown in this graph, in which Sergio Oliveira, he was showing what happens with driving pressures if you apply conventional PEEP strategy. This is body mass index in the x-axis. This is what happens if you use a standard PEEP. So you can have an increase in driving pressure during the surgery of more than 15 centimeters of water. But if you apply a strategy based on electrical impedance tomography or esophageal balloon, you can keep your driving pressure at very low levels during the whole surgery. Using this principle, investigators in Boston, they founded the lung rescue team, where they applied those principles in obese patients, and they achieved a remarkable improvement in survival. So let's see now one of the first randomized studies in pigs. This study is really interesting because although it's an experimental setting, it's one of the most beautiful results in terms of lung physiology recently. So this study was using 36 animals in which they had a model of ARDS promoted by lung lavage and ventilator-induced lung injury on top of it. And then they did PEEP titration. So collapse curve, hyperdistension curve. And then we selected a PEEP to be set overnight and divided in 3 groups. One group had to use a PEEP level with minimum lung collapse. Collapse could not exceed 3%. The second group used the PEEP very close to the crossing point, so minimum collapse and minimum overdistension. And then finally, a third group in which you had minimum hyperdistension, less than 3%. What happens with those animals overnight? You can see here that when I used high PEEP and low levels of collapse, my cardiac output suffered a little bit, but the animals went reasonably. When I had low levels of hyperdistension, a little bit of collapse, then the animals suffered right ventricular failure, as we are going to see. And this could be remarkable. And finally, the groups that stayed close to the crossing point, they went in a better fashion. In fact, the animals selected to low hyperdistension, so low PEEP levels around 8 centimeters of water, they had 50% mortality overnight. And this was caused by progressive use of norepinephrine and signals of right ventricular failure in the echocardiography. Also, in the histology, we could see that there was less protein extravasation when using the crossing point compared with the other 2 groups, and more alveolar homogeneity in terms of alveolar size. So this balance between collapse and hyperdistension was translated in terms of histology and proteins. And the most remarkable aspect of this study was shown in this graph. Look at the mean pulmonary artery pressure, and this is the PEEP titration. And here you can see the PEEP selected by EIT. So the lowest possible pulmonary artery pressure was achieved when we were working close to the crossing point. And then in another subsequent experiment in which we had bilateral lung injury or asymmetrical lung injury, so this animal has kind of more moderate ARDS. This one can be considered a more severe ARDS. When using low PEEP, we saw a big increase in pulmonary artery pressure caused by lung collapse. And lung collapse was causing capillary folding, kinking of corner or intra-alveolar capillaries, and alveolar hypoxia, increasing vasoconstriction, hypoxic vasoconstriction. On the other hand, especially in animals that had a little bit of normal lung, they were more sensitive to high levels of PEEP, because in these animals, they have too much hyperdistension, increased intra-alveolar capillary compression. So you see the capillaries in the walls of the alveolar sacs, they were compressed and increased dead space. So this is, yeah, and again, EIT was giving us the best solution for both conditions, either in this model of ARDS or this model of ARDS, avoiding too much collapse and too much hyperdistension. A few words about the crossing point. How much the crossing point is could be replaced by looking at compliance or oxygenation. Let's briefly talk about this. The first thing that was shown by a recent study performed by a group of investigators, a multi-center physiological study called the RECRUIT trial, is that the crossing point is not the same thing as the best compliance. And so you can see a big spread of the optimum PEEP according to maximum compliance. And the reason can be found in this study shown by Bouchan, Katira, in which they were doing PEEP titration in supine or prone. And you can see here the global compliance curve of this animal and the point of maximum compliance. And then they divided the lung into non-dependent and dependent parts. The dependent part is here, maximum compliance around 15 or 16, and the non-dependent compliance, maximum compliance around a PEEP of 8. So what is this showing is that the maximum compliance is matching the dependent compliance, and which means that by applying a PEEP of 15, you are going to prioritize this lung, but this other lung, the non-dependent one, is going to present huge hyperdistension. When this animal was in prone, now you have a better alignment of compliances, as was predicted by the physiology, because you have a more homogeneous and a lower gradient of pleural pressures. And now the dependent maximum compliance matches the almost the non-dependent compliance, and both are very similar to the global lung compliance. So one of the protective effects of prone position is because it's easy to make everyone happy, because every lung region is almost happy at the same PEEP levels. And here in supine, you have a much higher, larger discrepancy between PEEP requirements. Doesn't mean that you need less PEEP in prone, but you have at least one solution that makes everyone much happier than in supine. So remember, compliance gives high priority to the dependent lung. And this is where EIT can give us a very nice clue, because it shows very nicely that you may have too much hyperdistension here. A few words about oxygenation. Since the ARMA trial, where we reduced tidal volume, so we started with 10, the control group went to 12, the treatment group went down to 6, we could see that the treatment group, the group that had better survival, had worse oxygenation. This is already telling us that tracking oxygenation should not be a good target. PO2 cannot be a guide for our strategy. In this particular paper, we analyzed a little bit better this situation, checking if increments in PEEP that were followed by increased oxygenation, they had a good prognosis, they implied in a good prognosis for those patients. And the result was that whenever we increase PEEP and driving pressure dropped, this was very good. Or vice versa, if driving pressure increased when I increased PEEP, these patients had increased mortality. The same thing for the EXPRESS study and for the OVULA study. But when I look at the oxygenation, patients with better oxygenation after the increment in PEEP, I don't see any effect and any prognostic information, and the same for both studies. So changes in oxygenation are not telling us if we are doing good or bad. What matters is just the change in driving pressure. In contrast with these surprising results in terms of oxygenation, if we look at the recruit study, we can see that EIT is giving us a very important information. For instance, if I look at the baseline oxygenation of these patients, so 100 patients divided in low recruitability, medium, and high recruitability, I can see that oxygenation was exactly the same. Okay, so there is no difference in terms of oxygenation between this group that has very few units to be recruited and these patients that had a lot of collapse and very recruitable. So these are the level of recruitability, so the percentage of lung that could be recovered by a gentle recruiting maneuver. So some patients had more than 70% of the parenchyma collapsed. Remember that these results can be reproduced by CT studies. So in terms of oxygenation, all these patients, they had exactly the same oxygenation. But when we look at the EIT, the low recruitability patients, they needed in average 10 of PEEP, and the high recruitability patients, they needed 16 of PEEP. So there is already a big gradient of PEEP in these two groups of patients, but it's important to show that there is big individual variability, which means that you have to titrate PEEP for each individual patient. But at least in global numbers, we can see that EIT can provide a very important information in terms of how to select PEEP in those patients. So obviously these patients, they have much less overdistension than these patients when submitted to high levels of PEEP. And now finally, I'm going to present the results of this trial that was recently accomplished and was performed during the COVID pandemic, in which we used EIT to titrate PEEP in all patients. But some patients were randomized to use the ARDS-net PEEP and some patients to use the EIT PEEP. All patients had a low level of lung compliance. And how much PEEP EIT was indicating? Not much, because you can see that when I compare with all patients were titrated according to the ARDS-net PEEP FiO2 table and according to EIT. And as you can see, going from the ARDS-net PEEP to the EIT selection of PEEP, in many patients, we see a drop in PEEP levels. And in some patients, we saw some increase in PEEP levels. So I cannot say that I'm using a higher PEEP. I'm using a different PEEP level, a PEEP that is better suited for patient physiology. So as a result, it's a logical result. PEEP levels were not so different, but when we measure collapse, and hyperdistension, they are much lower when we use the PEEP selected by EIT. As a result of this trial, the trial was very small and we could not show any results in terms of mortality, but at least we could show one hard outcome that was the use of supplemental oxygen. So the time in between the patient was intubated until getting out of the ventilator and out of supplementary oxygen. Why we use this endpoint? Because you observed that many patients with COVID, they were out of the ventilator, but they had to stay in the hospital to use supplementary oxygen for many days. And then we could observe a difference of 8 days between entrance in the ICU and the discharge of the hospital. So oxygen-free days is something that is receiving increasing attention in the last years. It's an interesting outcome, which was already called attention in this paper, and also in this paper from our group a few years ago, where we showed that patients after the post-operative surgery, suffering cardiac surgery, if you use let's say, individualized strategy, you could reduce the use of supplementary oxygen along the days. And as a result, you can discharge the patients 2 days earlier or up to 3 days. So this PEEP titration with EIT is receiving increasing attention. I'm not going to show you many studies that are published in the last years, especially coming from China, but I can tell you that they are plenty. Many of them, they are showing improved survival, and this is maybe is going to be confirmed in future studies, also in the Occidental world. But we have had a lot of studies showing physiological benefits of this method of PEEP titration. And finally, I would like to say a few words about one aspect of EIT that is receiving increasing attention, and especially for PEEP selection. This is a patient, in fact, an animal receiving mechanical ventilation monitored by EIT. So the image of EIT is showing where the air is going during tidal volume ventilation. Then we performed selective intubation in this animal, and look at this. This is interesting to perceive that we still have some air here, but because of selective intubation, this lung is not being ventilated, and EIT is only showing us an open lung that is being ventilated. This could be considered a limitation because I don't see this pocket of air, but in fact is a big advantage. For instance, you can now have an easy interpretation in clinical conditions. For instance, in many experiments, many different scenarios, when I have some kind of lung alteration, a pneumonia, I see a silent zone here. If I see unilateral ventilation, despite the fact that I see some air here, I see just unilateral ventilation and this zone is silent. If I have too much collapse or pleural effusion here, I see all this silent zone. So the location of these silent zones can give you a very important information, very easy interpretation. For instance, if you have less than 40% dorsal ventilation, your PEEP level is insufficient, like in this image. And this has been used by Takeshi Yoshida to classify patients in which EIT looks homogeneous or absent dorsal ventilation, absent ventral ventilation. And remember that when we do PEEP titration, if you're using insufficient PEEP, your ventilation gets very ventral. If we use too much PEEP, your ventilation gets very dorsal. So whenever we are using enough PEEP, we are close to 50-50%. In fact, slightly more in the dorsal lung regions. By classifying the patients according to those principles, Takeshi showed different stays and different complications in the ICU. So, whenever you see a patient in your ICU that has absent dorsal ventilation like this one, you have to remember that this is caused by PEEP choice and you can reverse it. And this is exactly what we showed in this paper in JAMA. We reversed the absence of dorsal ventilation and we had an improved outcome of those patients. So this is the summary of our presentation. I will stop here. First, PEEP should not be titrated by oxygenation. I think we made a case about this. Second, EIT can quickly detect gravity-related problems, especially when you see absent dorsal ventilation. And for the first time, we can avoid overdistension with a good rationale, and we can achieve best hemodynamics simultaneously if we use EIT to guide us on the PEEP choice. Thank you very much. I hope you can understand my perspective about these exciting times in which we have a better tool to titrate and to guide us at the bedside. Thank you very much.
Thank you so much, Professor Amato, for such an informative presentation on electrical impedance tomography in ARDS. And at this moment, I would like to open the floor for a few questions, and we'll take it from there. Well, hello, everyone. And thank you for joining us. Thank you, Professor Marcelo Amato, for such an insightful webinar and discussion on EIT in ARDS. We have a couple of questions. I'm going to check the chat on YouTube and LinkedIn, but so far it looks like we have 3 questions. Is there anything that you would like to say before we get started?
I would like to say a few words about this presentation of PEEP titration in ARDS. And the point I would like to make is that along the years, we had an evolution of strategies from those ones applied exclusively in ARDS to those applied in general to mechanical ventilation. And then someone could think that, this is important only for ARDS. But in fact, along the last years, we have shown that everything that we discover as an important aspect of ventilation during ARDS came to be as important in the daily life of any intubated patient. It's more or less like the technology that we learn with Formula One, and then this is now in our daily cars. We have safety belts, we have all the mechanisms to guide us against, let's say, some getting out of the line, of the lane in cars. So the security is improving, and I think the same is happening during mechanical ventilation. So I really would like you to pay attention to those details. For instance, oh, my patient doesn't have a homogeneous ventilation. You could think, oh, I have been doing this for years and doesn't cause me any trouble. You have always to remember that mortality in mechanical ventilation in the best ICUs in the world is still 40%. 40% is a number that cannot be accepted.
Thank you so much,
And
Dr.
yeah, and then just as a result of this, every time I see a patient that I'm not understanding very well what is happening. I always ask to my residents, did you use EIT? Did you put an esophageal catheter? Did you record the desynchronies? And I think this has to be the ventilation in the future.
Thank you so much, Dr. Marcelo Amato. And definitely seems like we're moving in the right direction. Obviously, one of the main problems is that not every hospital can have this type of technology, right? It's very difficult to get electrical impedance tomography. Most academic centers may have it. In my hospital, we used to have it for research purposes. After our Dr. Beitler left and went to NYU. You know, he took all that stuff with him, but definitely something that every hospital should have in the near future. But let me get started with the questions. So there's a question from Raluca Ungurianu. Sorry if I messed up the name. And he's asking, how are the advantages to use EIT in bilateral pulmonary contusion to obtain a better ventilation and reduce the risk of ventilator-induced lung injury?
Yes, I think, thank you very much for this question. Bilateral lung contusion is never completely bilateral. And this is something, again, that it helps when you have a good monitoring, because typically you can see that you have one lung with a little bit higher compliance than the other, or one lung receiving a kind of asymmetric ventilation in terms of time, because it's very important to see that the time constant of one lung is very different from the other. And then everything could be a signal that you have to play with some tricks at the bedside, like lateralization, like selective intubation for a few hours to reverse the picture, and then going back to bilateral ventilation. But I would stress very much the importance of position, because position is something that we have never played too much because we didn't have the tools. And just to give you an example, having one side of the lung lateralized in terms that, okay, one side, let's suppose that I do lateral decubitus with 45 degrees, okay? The lung that gets to the non-dependent situation automatically is receiving 10 centimeters more of PEEP than the lower lung. It's not exactly the PEEP that is different, because PEEP is the same, but transpulmonary pressures are going to be so different as if I was applying 10 centimeters more or less in different lungs. So position can help you a lot under these conditions. And always we have always to put the bad lung upwards. So automatically he is going to receive higher PEEP or higher transpulmonary pressure.
Thank you so much, Dr. Amato. And we have another question from Mauro Castro Sayat. He's from Argentina, and he's asking, what is your opinion regarding the use of EIT in obese patients with a BMI higher than 50? Do you consider adipose tissue to be a real limitation? And if so, what factors should be taken into consideration?
Okay. Thank you very much for this question. This is an important topic, and has not received enough attention. And not only this, sometimes I have seen in guidelines or even seen in textbooks some wrong concepts about obesity. The problem is that, first of all, obesity is not a limitation for monitoring. You can have a very good image with EIT, you can have a good CT. Obviously, the signal to noise ratio deteriorates a little bit, but with the current technology, we have enough precision to measure everything that we need. So it's not a limitation for the technology, but could be a limitation in terms of the management for two reasons. First, there is a wrong concept that these guys have a stiff chest wall. And this is not true. Obese patients have a mass load effect, which means it's like putting some weight on top of the chest. And if you have read some recent papers that published by John Marini, Laurent Brochard, they are specifically addressing the point that you can put some weights on top of the thorax and you can improve your distribution of ventilation in some cases. So putting some weights creates a scenario in which you need a little bit higher PEEP, but once you apply this level of PEEP, you have absolutely normal lung mechanics, the same driving pressure, and the same oxygenation, and you can achieve brilliant results. So I don't believe that obese patients had a limited prognosis during mechanical ventilation. They can have, in fact, we can use what we call the obese paradox. Obese patients, they have more reserves, so they can survive more. When they are under mechanical ventilation, they survive less, but because our management is bad.
Mm. I think we definitely underpeep a lot of these patients that are very obese. They tend to have plateau pressures above 30, and of course, we don't have a esophageal manometry on them. So a lot of people tend to freak out if they're on people 14, 15, when in reality they may need
Exactly.
more than that. Thank you so much,
Absolutely.
Dr. Amato. We'll move on to the next question from Coletti Jr. Jose. He's asking, do you think EIT is well established in pediatric patients with PARDS? And are there any RCTs going on in pediatric patients using EIT? Do you think EIT can identify different phenotypes of patients that respond or not to lung recruitment?
Wow, these are all excellent questions. And I think I would have a very positive answer for most of the questions, especially now after reading, for instance, this very insightful paper from Kemani and his group, where they applied a strategy guided by esophageal pressure. And with this, they achieved a very good outcome in pediatric patients with acute respiratory failure, not only in terms of managing the acute cases, but also the weaning procedure. And like esophageal balloon, I think EIT can give you complementary information and helps you to, let's say, to individualize your care. So for sure, we don't have yet a clinical trial, a randomized trial on this, but I know that some centers are already starting it. And there is no big difference between pediatric and adults in terms of physiology, in terms of the capabilities of monitoring. In fact, the signal to noise ratio tends to be better in pediatric patients, and we have very sharp images. So I truly believe that this is the future. And there is one personal point that I would like to make. In general, the pediatric patients, they receive a lower quality of care as compared with adults. And the reason is because of the lack of monitoring. It's very common, for instance, that I go to a pediatric ICU, I see a patient doing spontaneous breaths on top of a BiPAP or pressure control with 25, 30 centimeters of water of driving pressures. This would be prohibitive in adults, but we do in pediatric patients because we believe that the spontaneous breaths on top of 30 of driving pressure is not going to damage a pediatric patient. This cannot be true because it's not true for any single animal. So I don't believe that pediatric patients are different.
Thank you so much, Dr. Amato. And we'll just take the last three questions very briefly from Ryan Freed. How does EIT compare to stress index for determining optimal PEEP? Are they similar or is one preferable than the other?
Oh, Very interesting question, and especially because there is something very new for the next years about EIT. Because nowadays, all the brands, the technologies are around, they put some priority in the distribution of ventilation. And then, so when you have a brighter image, it means that that region got more ventilation. Now we are developing a new way of using EIT. I don't have time here to explain, but it's like having a stress map, and then you are going to see immediately, look at the image, regions suffering higher or lower stress above a certain threshold or below a certain threshold. And we have seen beautiful images, for instance, showing that if I use too much PEEP, I see too much stress, and especially sometimes in the non-dependent regions. But to our surprise, also when we use insufficient PEEP, we started to see very bright regions in the non-dependent regions because of the baby lung effect. So in the future, we are going to have this stress map as something else to give us instantaneous ventilation, instantaneous information to guide our mechanical ventilation.
Thank you, Dr. Maro. Definitely very interesting and very exciting for the technology that's to come because we no longer have to perhaps order a chest x-ray, go on a CT scan. Perhaps we can detect live when a patient has a massive pleural effusion or when we're having a pneumothorax, a spontaneous pneumothorax, and when we're trying to optimize PEEP and we can see regional overdistension on certain areas of the lung. So definitely
Yes.
very exciting. So thank you for that. We have one more question from Troy Whitaker, and he's asking, when you talk about PEEP and adjustments to increase dorsal ventilation, what difference does it make when considering a passive versus an active patient?
Oh, thank you for this question. It makes a big difference, and this is, for instance, typically when you have spontaneous ventilation, there is a trend of having more dorsal ventilation. But it's interesting that in the same way in which we consider as a risky condition to have too much dorsal excessive PEEP, when you have spontaneous ventilation and you have too much dorsal ventilation, it also has a bad meaning because it means that you are making too much use of your diaphragm. And we know that when this happens, typically, for instance, if you see, I have seen patients with 100% dorsal ventilation. And Laurent Brochard, in a series of cases now, have reported patients, lots of patients with 80%, 90% of dorsal ventilation. And this was a signal of a bad outcome because typically this means that the diaphragm is working very hard and the dorsal ventilation is a representation of the pendeluft. Because pendeluft, think about when you have pendeluft, you have inward movement of the chest. So this decreases the measurement of ventral ventilation, and obviously you're promoting more dorsal ventilation. So whenever you have pendeluft, the dorsal fraction of ventilation increases a lot. Whenever I see more than 70%, I'm suspicious that this patient is presenting pendeluft, and then I have to do something to decrease the work of breathing.
Thank you so much, Dr. Amaro. And we'll go ahead. I'm sorry we're bombarding you with so many questions, but there's so many interesting questions. We'll go ahead and ask the last question, just for time constraints. And this is from Laubert Christoph. A further reason for the best compliance approach, not correlating with EIT, aside from ventral and dorsal inhomogeneity, could be tidal recruitment. Is EIT useful for detecting tidal recruitment?
Oh, this is an excellent question. Yes, you are completely right. Tidal recruitment affects a lot when we are measuring compliance. And this is the reason why typically for the same PEEP, compliance tends to be a little bit higher when I increase tidal volumes. So the change in compliance with tidal volume is a signal per se that you are having tidal recruitment. And for some reasons that I don't have time here to discuss, EIT is less sensitive or is less subjected to this kind of problem. And in fact, we have some tools to detect tidal recruitment. And the tools are related to the pattern of local inflation, because tidal recruitment is typically inflation of some pixels that happen later in the breath, not early on. And then we can detect this using EIT.
Well, thank you so much, Dr. Amato. I think we're gonna have to conclude these questions because we just keep getting more and more and more. But I really want to thank you for your time. I know you've been traveling around back and forth between the U.S. and Brazil, so I really hope that we can have you in the near future again for another presentation. But thank you so much for your valuable insights on EIT and ARDS. Thank you so
Thank you,
much.
Javier. This was a great pleasure. Very nice, let's say, chair.
Thank you
Thank you
so
very
much.
much.
Thank you so much, Dr. Amaro. And now to everyone in our audience, thank you for being here with us today. Whether you join us from Zoom, LinkedIn Live, or YouTube, we definitely appreciate your engagement and thoughtful questions. Um, I just want to, before we close, just have a quick reminders. A recording of this session, along with all related resources, will be available to register attendees. And please just be sure to follow us on YouTube and LinkedIn for announcement, replays, and future educational content. And most importantly, don't forget to sign up for our next major webinar happening on August 27th at 3 p.m. Titled ECMO in ARDS From Rescue to Refinement, Global Perspectives from the Pioneers. And we'll be joined by none other than Professor Eddie Fan, Professor Alain Combs, and Professor Gail Speak, three of the most influential voices in ECMO today. And they'll be discussing patient selection, timing of cannulation, and what's next for ECMO in the management of ARDS. Just remember that seats are limited, so we'll see you next time, and we hope that you register for the next webinar. At this moment, we'll conclude this session, and thank you so much to everyone that participated. Thank you to the moderators, and thank you so much, Dr. Amato and Christy Rose, for also making this happen.
Thank you, Javier.
Thank you, everyone.
Thank you, everyone.